Okay, good afternoon to all of you. We come to another important aspect of ultrasound, and that is in the D part. Now we have talked about A, we have talked about B, and C, and now we come to D. More important is what we commonly do. Any patient with suspected head injury, we rush to see the GCS. Okay, that should never be done. Only after ABC should we go on to D, and I will illustrate with an example. So this is a 58-year-old man who fell down from a roof in a rural village. His initial GCS was 12. Everybody is aware of GCS scoring system, very good. And after 2 hours the GCS became 6. So what injuries would you suspect? Better on, batao. Very good, could be head injury. Anything else? C spine, very good, bahut acha. Blunt thoracic, so could be anything. So there could be multiple injuries in this patient, but any patient you should always, in a head injury, you should always suspect a concomitant cervical spine injury. That's number one. Number two, from this scenario we are showing that initially 12 means he had moderate head injury, right? GCS between 9 and 13 is moderate. So if any patient which comes to your emergency, the take home message is the patient requires frequent re-evaluation, clinical re-evaluation. It's not that the first time you saw, that's the end of it. A lot of times it happens that you don't examine again. This is a dynamic kind of thing. Every patient can deteriorate or improve with time. So you need to evaluate that frequency, you have to decide. So what we say, what are the components of D? Components of D, anyone? Yes? What are the components in, what do we test in disability? Lateralizing neurological signs, yes? GCS and pupillary reflex, very good. 3 things we are seeing. When we talk about lateralizing signs, we are not doing a complete neurological assessment, we are just seeing if he is moving one side less or not, that's all. Okay. So what is severe head injury? We know it's GCS between 3 and 8. We have to, obviously, irrespective of what the patient is, we have to intubate as soon as GCS is 8 or less. Even though airway is patent, saturation is full, we have to intubate. That's very, very important. All of you must realize that. And why? Why do we have to intubate? Although saturation is 100%? Threatened airway. Threatened because because tongue fall can happen anytime because he's unconscious, and that is why, to prevent risk of aspiration, we need to do that. And as I said, it's a frequent re-evaluation we have to do. So like this is a patient which comes in, this is a typical scenario. Lot of times patient have been already intubated. Okay. So in this patient you cannot assess the verbal response because he is intubated. You cannot assess the eye response because there is bilateral black eyes. Okay. Only thing left is the motor response to check. So motor anyway is the most important response to check in these patients. So what are the pitfalls of GCS examination? As I said, we cannot assess eye, so eye is gone. So these are the pitfalls, and we cannot assess the ICP. Most important in part of head injury assessment is ICP, and in the emergency you cannot assess ICP, and obviously we can miss skull fractures. So can we use ultrasound to measure ICP? Some of you must be obviously knowing that optic nerve sheath diameter is there. Previously we used to put tegaderm, and over it we used to put jelly, but now we don't do, we just use tap water and dab it on the eyelid and then put the normal linear probe on the eyeball, closed eye. Okay. And once you do that, you may instantly get an image because the eyes are the windows to the brain. So you can do 3 things or 2 things. You can assess pupils, you can assess pupillary reflexes, and finally the optic nerve sheath diameter. Pupils, how do we assess? That's a beautiful thing, because everywhere the nursing note has to say pupillary size normal or reacting to light. You have to see for dilated pupil, because in case it is dilated, there is a risk that the patient may be herniating. Okay, there is no confusion on this. So pupillary assessment is extremely important, and Dr. Bowie is going to show you how the pupils appear on the volunteer. But here you can see how beautifully the pupil is visible, and when you shine light on a closed eye, you don't need to open the eye. So in black eyes it is beautiful, because through the black eye on a closed eyelid you can see the pupils, you can see the pupillary reflex, you can see for consensual and direct reaction to differentiate between optic nerve injury and third nerve, or in bracket oculomotor nerve injury. Understood? Why? Because the treatment is completely different. Oculomotor nerve injury, you don't need to do anything, and that could be a sign of herniation also. Optic nerve injury, you need to give steroids, optic nerve decompression, whatever is required. So this is the optic nerve, sorry, not the optic nerve, the pupils, and you can measure the diameter between this and this. You just do M mode and you can measure the diameter. So Dr. Bowie is showing right now, and we will get the. Yes. Yes. So I can. So can you see the reflex? See how beautifully it is, and this is the direct, and the opposite eye I show. You can see. Can you all see that? I'll show again. See, this is direct right reflex, and the opposite eye shine, and this is consensual direct. So eye doesn't need to open. Beautifully shown by Dr. Bowie, and you can then measure the pupillary diameter. So it is, instead of saying semi-dilated, dilated, you can have the nurses objectively chart it. So as soon as it starts dilating, you see 0.35, you know exactly what it is, what will happen 2 hours later. This is the objective way. Probe placement is, you have to place it almost vertical, because the pupils are like this. So you have to catch it like this if you want to see the diameter. So you have to place it almost vertical with the eyeball which is jutting out, and you have to what I call the fanning movement, so to get the best view in which you will see it vertically. Now is the raised ICP optic nerve sheath diameter. Most of you must have heard of it. You put your probe on the eyeball, okay, and because it's a rounded structure, you will get this anyway. You will see this kind of image where the optic nerve is seen posteriorly. So Dr. Bowie is going to show you here. So from the posterior margin of the retina, see the posterior, this is here, this is the optic nerve, and this. So you, from the posterior margin of the retina, you draw a line 3 millimeters behind. So we are drawing it 3 millimeters behind. At that point you measure from the darkest to the darkest. Okay, so he will show you. So we are going 3 millimeters behind. You can see here the screen. We will go 3, that is 3 millimeters. At this point we will make another marker and measure from the darkest. Up to 0.45 centimeters is normal. Between 0.45 and 5 is gray zone. More than 0.5 is abnormal and corresponds to around 20 centimeters of water. Okay. So here you see it is this is 0.7, it is normal, and you have to see in both eyes and get a average out of it. So this is a beautiful way of calculating of assessing intracranial pressure. And again I am saying we are not looking at very small values, you know. If the pressure is really high, you will get values like 0.6, 0.65 or something like that. So you definitely know that there is a very high raised, it's a high ICP. So we did a study here at our institution where we put in normal ICP monitors, and in those patients we simultaneously measured the optic nerve shine, and we got very good sensitivity and selectivity in these patients. Also there is the systemic review which has shown that it is now an established method of assessing raised pressure as a surrogate marker of raised pressure, and it can be beautiful in the emergency department for triaging your patient, which patient requires CT first, which patient requires neurosurgical intervention first. So if you have a lot of patients, you can just do this and find out, yes, this patient needs to be shifted to CT first. For it, that itself I think it is invaluable. So it can be very useful where ICP is not available, which is in the majority of the institutions in India. It is very reproducible, you can do lot of studies using it, and it is very easy to do. Now skull fractures, you know there are so many rules for doing CT of the head in minor head injuries. We are talking about minor head injuries now. These are patients who are walking, talking, had some injury, had a momentary loss of consciousness. Now you want to know whether we need to do a CT or not. So there are so many rules. Ultrasound can help you again. Why and how? If the patient says, I've got a pain here, you just put your linear probe here. You don't have to shave the hair, you don't have to do anything, no jelly, just put some water, normal tap water, and put your probe where patient is complaining of pain or tenderness, and you can see if there is a break in the white line, the skull. If the skull is intact, then there is no fracture. You don't even need an X-ray. So simple to do, but it requires you to do it. So skull fractures in majority can be a very good triage tool when there is a huge casualty or a lot of people coming in for after a disaster or anything like that. Scalp hematoma, again very useful. We have kids dropping off from mother's lap or from the beds, and they have a huge swelling on the head. Now you are also, you don't want to take a chance and you don't want CT done because it has radiation problems. You can do ultrasound and see whether this hematoma is outside the scalp bone or somewhere else. So most of the time you can see that the hematoma is outside the bone and the underlying bone is normal. There is no fracture. So then you can decide whether you need to go ahead or just observe the patient. Again, very nice and easy to do. Now can we see through the brain like we see the liver or spleen? There are two scenarios, in patients whom we have operated upon. What is the surgery neurosurgeons do? Decompressive craniectomy. So what is decompressive? You remove the bone flap. So once you remove the bone flap, the organs inside of the brain, that's only one organ, is visible to you like the liver or the spleen. You understand? So it's very easy, and these patients frequently come back to emergency with some problem or the other, and you need to rule out. So you can actually, like this example, you can actually put your ultrasound probe there. This is a patient who had bifrontal. When you put your probe, see how beautifully you can see the brain. It's like an MRI. See, and you can see there is some ventricomegaly, there is some collection here on the hairs. Can you see that? So this collection is also there, and you can rule out what are the most important complications after decompression. You can get hydrocephalus, you can get some collection subdural or something like that. And that's an abscess. That's all the three, and you can see all these very nicely. This is another patient. You can see how gross the hydrocephalus is, the ventricomegaly, very clearly seen. And here you can see a subdural hematoma, and this white line we just pointed out because I want to show you. This is the falx cerebri. All of you understand that's the midline. Okay, it's a and how beautifully it is seen. Now when this is seen in which the bone is removed, can we see anything when the bone is intact like all of us? Yes, we can. Can we? This is again with the bone removed, but here if you use the convex probe, the small cardiac probe, you put it on the temporal bone in the horizontal manner, you will get this image. Any patient, without shaving the head or anything, just put it there with some water. You can't recognize anything. All you can see is the inner table of the opposite side and the midline, the falx, which I was just talking. Can you see that? So it's very easy. You measure from the pointer to this side and measure from here to here, and then you keep it on the opposite side and again do the same. So then you have an average value and you can calculate what is the midline shift. Understood what I am saying? So you can actually calculate the midline shift in any patient using the ultrasound, and again you can triage patients based on the midline shift. Obviously in children who are less than 18 months, because the fontanelle closes around 12 months, but it remains cartilaginous up to 18 months. So your ultrasound will still penetrate it and you will get beautiful view. You can see this is the coronal view through the open fontanelle, and this is a sag view. You can actually see the CSF flowing through the foramen of Monro here, all through, and this is the brainstem across. So beautifully you can see everything in the brain, beautiful views. And this is a patient who came with EDH. He already had a CT scan, but we just put the probe on the fontanelle. See how beautifully you can see everything. So, ultrasound is beautiful. This is an abscess patient who had decompressive done previously, and again you can see the abscess, and we tapped it in the emergency itself. So, there are a lot of possibilities of ultrasound. And the final thing which this was another innovative thing we had done was using ultrasound as a screening modality for cervical spine fractures. Now, spine fractures nobody uses ultrasound, but we were the first in the world. Actually, we started doing it, and later Dr. Bhoi gave us a thesis to one of his students also. And what we are saying is cervical spine clearance is very important, otherwise you have to do a 2-point fixation on the skull before you intubate or do anything. So, what we are saying is that we are not trying to rule out linear fractures, we are trying to rule out potentially unstable injuries, so that if you extend the head, the spine is going to give way. So, that unstable injury can be easily seen using the ultrasound. So, how do we do that? This was initially we tried the posterior approach, but obviously in trauma patients you cannot do it from the posterior. So, we tried the anterior approach, and this is I have just put the CT scan horizontally for you orientation. And when we keep a ultrasound probe here, Dr. Bhoi, can you want to show? So, when you put your ultrasound probe in the anterior triangle of the neck, again the linear probe, you can actually see how beautifully, I will just show again. You can see every vertebra which is there. See, each vertebra with the intervertebral disc and everything you can see in the spine. And this is how we do it. This is the sternocleidomastoid, this is the midline. So, between the sternum you just put your probe there, move it up and down, and you can go through the whole spine at least from C3 to C7. So, we did and you can actually change it, and you can see the anterior longitudinal ligament also. This is anterior, posterior, superior, inferior. See how beautifully the bodies are seen. Anterior, you can see the intervertebral disc, you can see the facet joint, the nerve coming out from here. See, this is one, it looks magnified, each disc looks very magnified. This is the disc, sorry, this is the body, and this is the disc. Can you see that? Can you appreciate it? The shape of the bodies, can you see we are going up? So, very easy. And if there is a break in the white line, I want to show you, suppose there is a fracture like this. This is an unstable injury. The CT scan you can see, and this is how it appears on the ultrasound. You can actually see the break, and Dr. Bhoi showed beautifully, and you can see the break in the cervical spine, and obviously you know this patient got grossly unstable spinal fracture. Although you have not done any X-ray, you have not done a CT, patient just come in the emergency, but you can diagnose the unstable spine. That is a beautiful way in the emergency. See, you can see the break like here, and you can see what is the there is a break in the white line. So, we did a feasibility study, already patients had CT scan, but just to confirm, and we could detect 100% in all patients who had cervical spine instability. We are not talking about simple fractures, we are talking about instability, listhesis. So, cervical ultrasound can be useful in a lot of patient unstable injuries, and ultrasound in itself may be useful in disability. Again, I have shown you a window to a disability part where it can be used tremendously. Only it requires is your imagination to take it forward. Any questions? If not, thank you so much.
The last part, and right now we are reviewing it for publication. Okay. Yes. So we are just reviewing it for publication. Soon you will see that paper, and then we are going to do a multi-site study on that. It is very interesting that we also tested in few patients, but prospectively we have done with very good results. So, this is something new. So, we wanted to share with you. Now, what we will do is we will take you through the last lecture of the lay, that how you can use it in the code blue. अरे वो लोड कर दो लास्ट वाला साउंड ठीक एक मिनट ठीक ओके So, how many of you are using ultrasound during cardiac arrest protocol? Raise your hand. Okay, good. 1, 2, 3. Okay. So, the basic ethos of doing a high quality resuscitation as per 2018 guidelines is to achieve a CPR or chest compression matrix of more than 60% with minimal or no interruptions, right, minimal no interruptions, and following the 2018 guidelines, the changes to provide a high quality CPR. But if you have seen that the education, medical education system in our country is so variable that we are more theoretical and less practical in this part of the world. That is why we have seen various paradigms of chest compression, to doing a pathetic CPR, to also doing a high quality CPR, high quality chest compression. We have seen both, and we are seeing every day, because skill component has not been mandatory in the medical curriculum except anesthesia and acute care disciplines. So, now we are talking about a high quality CPR or a ultrasound guided CPR. Oh, come on, give me a break. You must be thinking about that, but nobody can, one cannot still hold on ourselves not to provide a high quality CPR. So, let us see that how actually, how actually we are providing CPR, or the CPR which we are doing. Is it on karo? So, you see that the chest compression till it gets up, the chest compression which we are doing right now, is it effective? That is number one. If I tell you one more story before we come to this thing, is President Kalam, while giving lecture in Shillong, he collapsed. And was he given CPR, Charu? He was not given CPR. The doctor was standing like this, behind like this, just on the back side of the President of India. So, if he did not get a chest compression, the common man cannot expect a high quality CPR. That is the crux of the story, and many lives are lost due to not providing timely chest compression. Chest compression, defibrillation, they are two most important things in the code blue which can save lives, and picking up reversible cause is the third thing which can save the life of an individual. Also, we have heard various stories where high quality CPR has really saved life. Very recently, somebody was flying on the flight and suddenly saw arrest, and immediately one doctor was there who knew how to do a high quality chest compression, actually saved that individual. So, let us see, we have heard various paradigms of CPR, and let us see how this gentleman is giving CPR. ठीक है उतना बस 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 So, he did a great Samaritan job. You see that he actually used what is called as the frugal innovation, the Jugaad technology. He did a great Samaritan act. How many of us will really resuscitate a patient in the roadside? So, that is the key question, Mr. Bean asked through this video, and that is why I said frugal innovation for him. He was a lay person. But here we are going to use a frugal innovation which is very recent, and we will understand, is there a need for point of care sonography integration? Can we pick up treatable causes of cardiac arrest? Can we use it during peri-arrest procedure? And we know that each CPR is labor intensive. It requires high quality, high labor intensive, and is my resuscitative efforts are going to give dividends or it is futile. So, let us see from the famous statement of flying blind to flying right. Most of the CPR, you straight away jump on the chest, start compressing, and simultaneously you should address the treatable causes. but most of the time we do not understand why it is we are doing chest compression. So, that is why flying blind means a patient of tamponade, if you keep on compressing the chest without addressing the problem, will it come back, Shravan? Or tension pneumothorax, will it come back? So, that is why, so what we say is the famous statement of flying blind to flying right. Got stuck. Yeah. Okay. So, the pitfalls, differentiating between pulseless electrical activity from pseudo PEA, determination of cardiac standstills. Many a times the fine VF will appear as a cardiac flat line. So, rather than so many times get confused and you have to check in the flat line protocol, you have to increase the gain, check in other leads, right, and many a times you will miss the treatable causes of pulseless electrical activity. So, we know what are the pulseless electrical activity. Charu, can you just say some of the causes of pulseless electrical activity? 5H, 5T. So, you just say H, okay, one H. Hypoxia. Yeah. Next H. Hyperkalemia, hypothermia. We can't do anything by ultrasound. Yes, sir. Next H. Hypovolemia. We can find out that why the patient has a shock by ultrasound. Yes, sir. Next H. No, not hypotension. Yes. Next H. Next H. Hyperkalemia. He said that hypokalemia. We can't do anything by ultrasound. Yes, sir. Hypothermia. He said already. We can't do anything. No. H ion acidosis. Okay. We can't do anything by ultrasonography. Then come the T's. Yeah. Toxins. We can't do anything by ultrasound. What is the next T causing pulseless electrical activity? Majid? Yes. Tension pneumothorax. We can pick up by ultrasound. Yes, you can pick up by ultrasonography. We can make a difference. Tamponade. Next T is tamponade. Can we pick up by ultrasound? Yes, you can make a difference. Okay. So, these are the things. And what are other things, Sachin? Other two? T? Absolutely. Thrombosis coronary and thrombosis pulmonary. All you can pick up by point of care ultrasound focus. And two more things is you can also pick up fine VF. Okay. Fine VF, which will help you to give the shock. You may think in the leads, you will be seeing a flat line, but if you see fine VF, the treatment is different. One will go into a shockable algorithm, one will go into a non-shockable. Many times it will appear as flat line. You understand? That is how it makes a difference. But many times these are blind, the pitfalls of a CPR where you are not adjuncting with point of care ultrasound. So, is it a time for peri-arrest ultrasonography? Yes. The ever changing guidelines from 15:2 to 30:2 to ABCs to CABs, and now removing key elements of drugs like atropine does not have any sense, vasopressin has been taken out, and now they have had tube conformation if you are trained by ultrasonography. That is the 2015 guidelines says. But this we have been practicing since last 10 years, before ACL is adopted now last guideline. So, let us see what the literature says. There this was one paper which came in 2008 which said the same thing what we just now said to you. Okay. We have been practicing since the last 10 years, and remember that arrest can occur anywhere. No time, place is immune to a arrest, right, because now you will be saying you have to use ultrasound because of portability of machines, because the machines have miniaturization of machines, the machines have become like a smartphone. So, you can carry the machine anywhere. So, that means you can take it to the pre-hospital care setting in the en route in the ambulance, right. So, you can take that and use it. So, remember that you have to have a man, the machine and the protocol to use it, right. The machine should be portable, even fixed machine can be done, but more suitable. So, you can take it in your pocket as well. The man should be very proficient. You should be proficient in doing ultrasonography and it should be done in very quick time. But when and how, that is what there are many algorithms. People have used only focused echo as the cardiac arrest protocol, right. What we did as a group and we published also, we used the physiological interplay, the organ talking between the heart, the lung and the IVC. So, we wanted to find out the conversational problem between the heart, the lung and the IVC. So, let us see. So, when and how, this is what we published in API textbook of medicine, right. So, you give 2 minutes of chest compression, first cycle, and in the meantime you boot the machine. It takes some time to boot the machine. Okay. So, you give first chest compression is the key, high quality. In the meantime, you bring your activate your drug nuts, you activate the leads, okay. You activate the machine, it will take time. So, the first step is take the curvilinear probe, one probe is enough. Okay. You can scan the heart, the lung and the inferior vena cava, got it. So, in the first step we find out the lung window. You have a 10-second loop to do the rhythm check. Earlier it was pulse check, now it is called as rhythm check. So, during this 10-second loop you have to ask key questions in the heart. Is the heart beating, yes or no? Number 1. Is there a tamponade present or a pericardial fluid present in tamponade, yes or no? Third, is there a regional wall motion abnormality? If the chambers are looking alike, left ventricle, right ventricle, to rule out a pulmonary embolism, regional wall motion abnormality to rule out a acute myocardial infarction. Okay. Is the ejection fraction looking normal or poor? Eyeballing method. Okay. So, poor ejection fraction is a cause of arrest or yes or no. So, these are the 5-6 questions you need to ask you very clearly, or the heart is beating very fast. Is it hypovolemic? Okay. The LV is kissing. You understood? Either it is kissing or it is not contracting. Okay. LV. I am only interested in the LV first. Or is there a regional wall motion abnormality, or both the chambers are looking alike, or there is a fluid with heart is unable to expand properly, ऐसे दुबक के बैठा है ऐसे, because there is fluid all around. You understood? So, first thing, if you get an answer in step 1, you do the job. Okay. You have to do the chest compression. If it is thrombosis pulmonary, coronary, from pulmonary you give TPA. Okay. In extremis 50 milligram. Sorry. Okay. If there is ROSC, if there is a thing, okay, you can activate the cath. Okay. Or remember that if you the tamponade, you will put in a needle, right. If you do not find the answer or it is hypovolemic shock, then you have to treat hypovolemic shock simultaneously. So, if you do not find the answer, continue chest compression and all algorithm go to the lung window. Okay. Lung window, 5 seconds on the right side, 5 seconds on the left side. Mid clavicular line you have to put the probe. कहाँ पे रखेंगे आप? Mid clavicular line. That's it. And if you find majority cause is due to tension pneumothorax. If there is tension pneumothorax, what you will do? Shravan? Needle thoracic. Where you will put the probe or needle? Where you will put the probe? Sorry, needle? No. कौन सा ईयर तेरा? भाई तेरे को मैं एग्जामिनर आ गया छोड़ूंगा नहीं तेरे को. It is 5th intercostal space. Okay. So, it is 2018 guideline says it is changed. Okay. 5th intercostal. Except in pediatrics, it is still 2nd. Okay. So, if I do not find the answer, I will go to the IVC. What is happening with the volume status? Okay. So, this is how we are going to play, and we are going to play with 5 cases, right. So, Sachin, can you just go there? So, here Charu, can you read the first this thing? अब तुम्हारी नींद खुल गई अभी? Good. Okay, what do you think the cause of arrest is? Please have a seat. Very good. So, I will start chest compression. After 2 minutes, we will see the first the cardiac window. Let us see. इसमें नहीं आ रहा है सचिन. Shall I go back? Okay. Not happening. Just a minute. Let's try once more. There is some issue here. उसमें नहीं आ रहा. Yeah, not नहीं उसमें नहीं presentation view. Okay, go. Just close this window. Yeah, close this presentation window. Go on more presentation. एक मिनट और एक slide है. Let's see. देखो तो इसमें देखो. Let's check it. देखो हाँ इसमें देखो तो इसमें नहीं आ रहा. देखो जरा. Let's close one of the presentation. So, you see now what we will do is we will try to put you some of the case stories, okay, and how actually you can make a difference, right. So, for doing this much, this is the pinnacle of your proficiency, okay. So, you can't do as a beginner, remember this, because you should not hamper the code blue team. There is a different sonographer. Okay, the radiologist is not going to do for you because he is not trained in this. Remember this. So, you have to do in the 10-second loop. So, how do you make out 10 second? ये practical सवाल है. 10 second कैसे पता लगाएंगे आप? कल तुम मेरे साथ शिफ्ट में होगे, मैं तुम्हें फिर पूछूंगा ये. 1001. It is not 102. It is 1001, 1002, 1001, 1002. You keep on counting like that. Okay, and try to train yourself. Okay, so that you do in a 10-second loop, right? So that is what we think. Yeah, it aa gaya. So the first cardiac window is like this. You know, Charu, is there is the heart beating? Is there a pericardial fluid? No pericardial fluid. The chambers are looking okay. You know, yeah. So now we go to the next window. Yeah. Lung sliding present or absent? Charu? Lung sliding present. Okay, good. Present or absent? Okay, good. So what do you expect in IVC? Dilated or collapsed? Dilated. Very good. Let's see. So it is what? Dilated. What is the RA pressure in this? If you see hepatic veins, okay, we are seeing hepatic veins, the RA pressure is more than 15. Okay. So then you will search for a thrombus, right? So let's see, you know, ideally you may get a right ventricular dilatation, McConnell sign, you may get classic, you know, but sometimes you may not get, right. So you see this is the thrombus. So what you will do next, Charu? डोज बोलो बोलो दिया है तुमने 50 milligram. How many have given in extremis TPA? with pulmonary embolism? No one? I think you are given, AD team has given, we have given many. So, the second case is a 22-year-old male with penetrating trauma through the chest, comes in unresponsive. So, what do you think the cause of arrest? You have to anticipate, as a leader you must anticipate while chest compression is going on. Yeah, absolutely. Massive hemothorax which can cause, you do not say it is a simple hemothorax. Yeah, anything else? Yes, anything else you want to add? Tamponade, very good. So, let us see. So, sorry, I am sorry, yeah, just play the one. Yeah, yeah, what do you see, sir? Yes, can you just show? This is a pointer, ये pointer है और ये आपका इधर वाला, हाँ, चलो बताओ. What is that? Absolutely. And how do you say it is tamponade? What are the features are there? You are right. Patient has tamponade. That's fine. Anechoic shadow is fine. What are the features of tamponade he has? Ultrasound wise. Anybody want to add? Yes. कौन सा डी शेप में दिखाइए? No, that is not the sign of tamponade. Yes, yes, sir. ये रही है ऊपर वाला. Not D shape. D sign is not a feature of tamponade. You want to add?
Right ventricle is collapsed.
Yeah. Which is the right ventricle? Very good answer. What's your name? Sanjeet has answered very nicely. Let's have a big round of applause for him. So, this is what it is, the right ventricle. Just play it once for Sachit. Yeah, just explain them. So, first is you see this is a probe pointer. Okay. So, this becomes the right ventricle. Okay. And this is the left ventricle. You see the right ventricle diastolic collapse, right. In diastole it is collapsing, right. And you can see the swinging motion of the heart like this. It is floating in the lake of blood. If you take a ECG, what you will see? Sarvan. What is the classical? Arey bhai. Electrical alternance is the answer. Why you are saying other? There will be low voltage complex, okay, and electrical alternance. That's why it keeps on. है ना, ऐसे से हो रहा है ना. जब आप इलेक्ट्रिसिटी लेंगे तो कोई कॉम्प्लेक्स बड़ा आएगा, कोई छोटा आएगा, बड़ा आएगा, छोटा आएगा. Because heart is dancing. देखो डांस कर रहा है. You understood? So dancing, and second is right ventricle diastole. What you will do next? Yes, sir. What you will do next? What you will do next? Come on. Absolutely correct. You will do a pericardial synthesis. You did that. The cardiac pulse came up and again it went down. So let's see what happens in the next step is lung. Cardiac pulse आया, फिर वापस चला गया. Yeah, what do you see, sir? Lung sliding present, absent? Absent. This is absent lung sliding. What you will do next? Needle thoracosynthesis. Yeah. Next. So, what do you expect in IVC? Dilated. Yeah, because it is a obstructive shock. So, this is a dilated IVC. I am showing you all because you understand the physiology. That is why. Otherwise, there is no point doing IVC. Okay, remember this. Okay, let us see. Move to the case scenario 3. Yes, sir. You can read that. बैठ के read.
34-year-old man road extraordinary accident with a run over a abdomen. Tire marks present.
So, what do you think the cause of arrest may be? Okay, very good. So, let us see. Okay, cardiac. Let us see the heart one, cardiac as per the protocol. Yes, sir. Is the heart beating? Is there a pericardial fluid? No. How many of you say no pericardial fluid? Raise your hand. How many of you say there is a pericardial fluid? How many of you say there is a pericardial fluid? And the answer is there is no pericardial fluid. Okay. So, what you see the anechoic shadow, it is here only. Okay. So, if it is a pericardial effusion, usually unless it is loculated, it will be all around the in the dependent portion of the heart. You see, this is the pericardial pad of fat. Even that becomes anechoic. Remember this. Okay. Second, you see is slightly beating faster. So, in case of you are suspecting a hypovolemic shock, right. So, always remember that look at the left ventricle all the time. Okay. So, you see left ventricular squeeze, if it is going nearer kissing each other, that means the patient is volume depleted. Okay. Next, let us see the lung, right, as per the protocol. Okay. The Ames clip protocol, cardiac, lung and IVC. Yes, sir. What do you think? Lung lining present, absent. What will do next? Sir, what will do next? If you think so much, patient is already in arrest, then you don't have time to think. What will do next? Needle thoracocentesis. Which space? Absolutely correct. Okay. So, what do you expect? Yeah, Sachin, yeah. So, for right side absent, so you just see the left side as well, because sometime there may be other side also there may be a pneumothorax. Okay. Always check on the both the sides. So, is the lung lining present or absent? Present. Very good. So, what do you expect in IVC? Tension pneumothorax. What should happen? Dilate, collapse. What should happen, sir? In tension pneumothorax, should collapse or dilate? Dilate. Or do you agree? All of you? Tension pneumothorax should dilate? Yes. So, let us see. But what is happening here? It is collapse. Is the wrong video inserted? So, you think that there may be additional hypovolemic shock. You are right in thinking that. So, what shall I do next, sir? Fast scan. Let us do. Yes. So, what is it? देखो ये पॉइंटर है, थोड़ा प्ले कर देना सचिन. हाँ, yeah, play. Yeah. So, do you think, do you all agree with him? No, there is a fluid there. Yeah. So, why it is shaking too much? Can you see this? Yes, sir. ये स्क्रीन देख रहे हैं, हिल रहा है बहुत जोर से. तकलीफ से चेस्ट क्यों हिलेगा? Come on. No, no, wait. Huh? So, yes, the ongoing CPR. See, it is rhythmic. So, here we have not stopped the chest compression, and this is one more situation where you need not to stop chest compression and continue doing ultrasound, because you are away from the people who are doing chest compression. आप तो नीचे खड़े हो, okay, near the abdominal area, you can still do all the scans, right? So, that is why the chest compression is going on. Okay, yeah. Put the other, yeah. Look at here. Here, the anechoic shadow, the spleen is shattered, shattered spleen. Can you appreciate that? Let us go to the next window, Sachin. Yeah. Can you see this? The bowel lobes, and this is full of anechoic shadow. So, it is criminal to receive a patient like this in arrest. This patient could have been managed in the district hospital, isn't it? You are only putting chest tube for pneumothorax, and you have to do a laparotomy where civil surgeon is available, isn't it? क्यों ये पेशेंट डिस्ट्रिक्ट मैनेज नहीं हो सकता था? हो सकता है. You do a fast scan, okay, and the surgeon can easily do a splenectomy, and control the hemorrhage. We don't want patient to come to Ames Trauma Center to receive treatment. Doesn't require high quality, it just require a basic management, you could have saved such lives, and many lives are being lost because we do not have a robust emergency and trauma care system. This is a testimony of that. So, this I will take a 45-year-old gentleman with blunt trauma to the chest comes in unresponsive. Okay, we will see the cardiac, lung and IVC quick fashion, and you see we have received such patient many patients, okay, like this, and because of point of care ultrasound we have saved also many. So, let us play the cardiac. So, in quick second, in quick look I can say this is normal, okay, normally beating. Yeah, go to the next window. So, let us see how we will reinterpret quickly, right. So, B profile, no, not this one, I have moved on, I think, sorry. Yeah, now you play. Wait, it is going, Sachin, just a minute. Band karo, cancel. Yeah, once it that hand comes, then only you click. Just put the mouse nearby, that hand will come, then only you click. Yeah, now you click. Lung sliding present, okay, close the window. So, now I will read it fast. So, as how I will read. Wait, it is 5, it is 5, scenario changed, yeah. Let it come, yeah. It will come. See, lung sliding is absent here, okay. So, here left side lung sliding is absent. So, first I will quickly think that before thinking it is tension pneumothorax, I will think whether I have intubated into right main stem bronchus, if I have intubated the patient. समझ में आया? अगर मैंने intubate कर दिया तो I will, if I have intubated right main stem, there will be left side, it will be absent lung sliding. So, I will see, quickly see, if it is in a position, then I will put in a needle. It can be due to tension pneumothorax. You understood, all of you? So, if there is absent lung sliding on the left, check on the right side, check the tube is in position or not. If it is in position, it is the size of say 7, you put it in 21 or 8, 24, the size, and you find this is still in center and left side, if it is absent lung sliding, that is due to tension pneumothorax, okay, put in a needle, So, I will go to the next step, that IVC will be dilated in that case. This is another case where the patient of known case of coronary artery disease comes arrest, okay. Let us see in cardiac what happens. Here I will see only in the LV, you see this, I am only interested in LV. This I got a poor ejection fraction, okay. Hardly it is contracting, the cavity size should decrease by 30% to have a good ejection fraction. Second observation is, you see the anterior mitral leaflet, can you appreciate? You should touch the septum so that you say it is good ejection fraction. See, hardly it is coming here, it is just flickering, yahi pe flicker ho raha hai. You understand? These are 2 points to say that this patient has got a poor ejection fraction. This is a cause of arrest, okay. Yeah. So, what do I find in, what should I find in the lung? Sarvan? Normal A profile milega. If there is poor ejection fraction in the heart, it will be a wet lung. Yeah, let us see. B profile. Can you appreciate? This is a full of B profile. That means it is a wet lung. Okay, pulmonary edema. Okay. So, let us see in the other window also, we should see a complete B profile, and the IVC will be here, it will be dilated. Okay. Because it is a cardiogenic shock, you can see this, and IVC we will see, yeah, it close down, yeah, inferior vena cava, it will be dilated one because of the back pressure changes. Okay. So, here is some of the index cases, we put it out to you, there may be n number of index cases, but if you follow the algorithm like this, you will be able to catch many of the things very easily. Okay. Some you can make a difference, some you cannot, but at least you will come to know what you are dealing with, right. Procedures, you can guide procedures like needle cricotherectomy, you can mark it. Remember, every airway every intubation is a difficult one. Okay. Remember I told you in my last class, not this class, in our academic class, always consider all airway to be a failed airway and mark it before, because if you were failing it, you should be doing a surgical airway. So, mark it before every intubation. You can mark it clinically or you can use ultrasound help, right. You can do pericardiocentesis and you can guide the central lines, you can guide transvenous pacing. Okay, patient is complete heart block, you want to do pacing, you can transvenous pacing, you can guide central lines, you can do. Okay. So, this is the cricoid membrane and you can do a needle creaks. You can do pericardiocentesis. Okay, you can see that this white dot, pericardiocentesis. And the last segment is you have to find out is the baseline cardiac activity. Thus, what is the prognosis of this patient? A patient coming to you having a baseline cardiac activity like this, from a patient coming with cardiac standstill like this, initial, which one will have a better prognosis? It is a very simple thing. Yes, sir. You understood what is the question? Patient coming to the emergency and coming with this one, you did a scan with some activity. From a patient, another patient comes with this activity, that is the cardiac standstill. Which one will have a better prognosis in return of circulation at 24 hours? Anybody? The first one who has a baseline cardiac activity has proven that the return of circulation is better at 24 hours in patient with baseline cardiac activity to patients coming with cardiac standstill. Okay. So, I looked at while we were doing this ultrasound guided CPR in the very early years. So, I looked at literature and who is doing what. I use the search engines. So, beside what we said, you can also use it in transvenous pacing. Okay. You can make a fine difference between the fine VF and a asystole, because the protocol changes. This is what I looked at and said what we can do in pre-hospital care. You can integrate that because machines are coming smaller, and you can use in battlefields, in pre-hospital care, in jungle warfare, pneumothorax is a key issue, disaster management, patients are in the rubbles, one of the key killers in earthquakes are due to pneumothorax. Or you can do even, that is about arrest, non-arrest you can do amputation, blocks and all that stuff. And in the patient with ACLS algorithm you can use it, in maternal algorithm you can also use it. In maternal arrest algorithm, here you are not saving 1 life, but 2 lives. Okay. So, you should know what is the guideline for doing a ED cesarean section. Yes, it's what is the guidelines? Second year. Doing a ED cesarean section, what are the guidelines? So, it should be a witness arrest. It should be more than 24 weeks, right. Third, the baby should be viable, means once it comes out, he should be able to live, that is viability. Okay. So, viable, and you should be able to take the decision within 1 minute of arrival, and the baby should be out by the 5th minute. Okay. You understand? So, that means you have to do in the emergency itself. We have a set in this ED cesarean set. So, our surgeons are available, So, you have to do that, means you have to do in the ED. You have to open up and take out the baby, because you are saving here 2 lives. For that, you can use ultrasound to find out is the baby alive. Is the baby alive in this? Yeah. But this baby, actually the mother has fallen on 3rd floor. In this one, the baby was of 19 weeks. So, we could not save the baby. Okay. So, here in 1 minute you should see baby is alive, and for viability you should see the biparietal diameter and the femur length, okay, for fetal maturity. So, that you will know whether the baby will be able to live once it comes out of the mother's womb. So, once the patient comes out, suppose there is return of circulation, you can adjunct in the ABCD protocol again, because sometime you may have dislodged the tube. So, you can check the tube again, you would have created a pneumothorax, right. You see, rule out again. Now, you can do a hemodynamic assessment more detail. Okay. You can do calculate indexes like cable index, distensibility index, all as indices, velocity time integral, all that stuff. Okay. So, that is slightly higher stuff you can do at the the return of circulation, okay, and you can find out why the patient has arrested many a times in a detailed study in the tertiary survey of algorithm. Understood? How actually do it? You just see. You are using a curvilinear probe, sub-xiphoid view, less than 10 seconds you should take for rhythm check, first rhythm check, okay. Then you look at the lung window, so you do both 5 seconds on each. So, you do not do it in one, okay. So, this is just a simulation we did, but you have to break it up in 3 sections, okay, and you amalgamate into the CLIP protocol. So, this is how you do it. Practice yourself, practice the CLIP protocol. So, what we have done is we have told our residents to practice, now they are having sonography class every alternate day. So, what we are doing is training them to time themselves, okay, less than 10 seconds, and that is how you can integrate as a new chain of survival, that is point of care ultrasound, and building a new block to the existing block of chest compression, defibrillation, improving the chest compression matrix, and develop a quality of high quality resuscitation to the existing one. Thank you very much for your attention.